A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of melena. On examination, she was tachycardic and hypertensive at 121 beats per minute and 90 over 50 mmHg, respectively. She manifests pallor with no icterus. She is eupneic and normothermic, but reports intermittent periumbilical tenderness. Medication history reveals occasional intake of a non-steroidal anti-inflammatory drug, naproxen, 250 milligrams for arthritis management. On admission, her blood count revealed a hemoglobin level of 5.1, G over DL hematocrit of 32%, prolonged prothrombin time, and a positive Guaiac test. All other laboratory studies were within normal limits. Based on these clinical presentations, intravenous fluids were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal endoscopy was performed, which revealed a 1 by 1 centimeter hemorrhagic gastric ulcer. The bleeding ulcer was cauterized and biopsies were taken for Helicobacter pylori, the results of which are negative. Proton pump inhibitors were started and she was discharged after 2 days in a stable condition. A 58-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation in both feet and occasional blurred vision. The client admits to problems adhering to her prescribed dietary and medication regimen. She doesn't exercise regular, takes her medication only when she is reminded, and doesn't watch her diet. She denies dyspnea, polyphagia, polydipsia, polyuria, and diaphoresis. The client had a history of non-insulin dependent diabetes mellitus for 15 years and dyslipidemia and hypertension for 8 years. She had laser photocoagulation and retinopathy in the past year. She is on metformin and glipizide for control of hypoglycemia, hydrochlorothiazide, and Ripril as antihypertensives, and atorvastatin for hyperlipidemia. Upon examination, her blood pressure is 185 over 98 mmHg. Fasting blood glucose is 265 milligrams over DL. Hemoglobin A1C is 9%. Serum blood urea nitrogen and creatine at 53 milligrams over DL and 4.4 milligrams over DL, respectively. Urinalysis and 24-hour urine collection uncovered trace protein and urinary albumin excretion rate of 255 milligrams a day, leading to a diagnosis of microbilarium. Nerve condition studies and electromyography confirmed diabetic neuropathy. Decreased visual acuity and new extensive rectal vascular growth were revealed through an ophthalmologic exam. Based on the client's typical presentations, the final medical impression and diagnosis is uncontrolled insulin-dependent diabetes mellitus complicated by hypertension, dyslipidemia, neuropathy, and retinopathy, and microalbuminary.